Everyone. Welcome to the webinar conducted by Vijaya Diagnostic Center. I am Dr. Umashankar, consultant pathologist working in Vijaya Diagnostic Center, Kurnool. Today's topic is laboratory approach to hemolytic anemias. The speaker is Dr. Vasundhara. She is a consultant pathologist working in Vijaya Diagnostic Center, Kurnool. As it is a vast subject with various clinical symptoms, etiopathogenesis, pathophysiology, and it involves extensive laboratory investigations for arriving at a diagnosis. We are briefly discussing about the basic laboratory findings to approach a hemolytic anemia case. Now I invite Dr. Vasundhara to speak today's topic. Welcome, Dr. Vasundhara.
To laboratory approach for a hemolytic anemia. So hemolytic anemia is mainly because of premature destruction of red cells, premature destruction of RBCs, and there is a compensatory increase in the erythropoiesis in the marrow. So the hemolysis is broadly classified into extravascular hemolysis and intravascular hemolysis. Extravascular hemolysis occurs in the reticuloendothelial system, whereas intravascular hemolysis it occurs in the vascular compartment. Okay, in intravascular hemolysis, the free plasma hemoglobin released in the blood it conjugates with the haptoglobulin, and this hemoglobin haptoglobulin complex in the liver it is metabolized and is excreted as hemoglobin urea, and this hemoglobin a part of this hemoglobin is absorbed by the renal tubular cells and it's converted into hemosiderin, and the hemosiderin deposited in the tubular cells or released into the urine as hemosiderin urea. And a small fraction of these hemoglobin get converted into a methemoglobin. So in intravascular hemolysis, because the free plasma hemoglobin conjugates with the haptoglobulin, there is a decrease in the serum haptoglobulin levels. And you'll see a hemoglobinemia. Because of the hemoglobin in the blood, we have a hemoglobinemia, and you will have a hemoglobin urea and hemosiderin urea, which is not so the case in case of extravascular hemolysis. In extravascular hemolysis, there's an increase in unconjugated bilirubin, and you'll have a urobilinogen and stercobilinogen. So hemoglobin urea and hemosiderin urea and methemoglobin and all is not seen in extravascular hemolysis. So this is how the RBCs, lysed RBCs get metabolized in case of extravascular and intravascular hemolysis. This is the extravascular hemolysis where it is converted into unconjugated bilirubin and converted into urobilinogen and stercobilinogen and excreted in the feces and the urine. Here in the free hemoglobin released into the vascular component combines with haptoglobulin, and these hemoglobin when entered into the kidney it is released into the urine as hemoglobin urea. So this is a difference between a intravascular and extravascular hemolysis. So the differences. So the most common is extravascular hemolysis and the least common is the intravascular hemolysis. So yeah, as said previously, there won't be any hemoglobinemia or hemoglobin urea in extravascular hemolysis. Whereas in intravascular hemolysis, you will see a hemoglobinemia and hemosiderin urea, and a small fraction of methemoglobinemia is also seen in case of intravascular hemolysis. So in two previous slides, we have discussed about the extravascular and intravascular hemolysis based upon the site of destruction. Now the hemolytic anemias classified based upon the etiological factor. These are classified into extrinsic hemolysis and intrinsic or intracorpuscular hemolysis. Extrinsic is the factors not pertaining to the RBCs beyond the outside the RBCs, the extrinsic or extracorpuscular. So in extrinsic or extracorpuscular hemolysis, here it includes autoimmune hemolytic anemias, microangiopathic hemolytic anemias, direct toxic effects that is include drug, paroxysmal nocturnal hemoglobinuria and paroxysmal cold hemoglobinuria and tropical splenomegaly. In endemic areas of malaria, there is a splenomegaly, and because of this splenomegaly also the RBCs get sequestrated in the spleen and get destroyed, causing the hemolysis. And the intrinsic or intracorpuscular hemolysis, it includes hereditary spherocytosis. This is a structural defect in the ankyrin and spectrin protein. As a result of this, the RBCs they become spheroidal shape, and this is less deformable. So these gets entrapped in the splenic sinusoids and get destroyed. And other is the G6PD deficiency, where there is a deficiency in the G6PD enzyme, which is essential for the formation of reduced glutathione, which is essential for neutralizing the H2O2. So in case of G6PD deficiency, the H2O2 is not neutralized, and it converts the hemoglobin into sulfa hemoglobin and causes the hemolysis. And others are the thalassemias and sickle cell anemias. The thalassemias is a quantitative hemoglobin, and other is the sickle cell anemia.
PPT is not visible. PPT, can you display the PPT?
Audible and visible, sir. Umashankar sir, am I audible, sir?
Yeah, you are audible.
Okay. So hemolytic anemias are again classified into extracorpuscular or eccentric and intrinsic or intracorpuscular, depending upon the etiological factor of the hemolysis. Intrinsic or intracorpuscular, the defects are within the RBCs, whereas in intrinsic and extracorpuscular, the etiological factors are beyond the RBCs. So, extrinsic or acquired or extracorpuscular, it includes autoimmune hemolytic anemias, macroangiopathic hemolytic anemias, direct toxic effects, paroxysmal nocturnal hemoglobinuria, and splenomegaly. Whereas intrinsic or intracorpuscular, it includes hereditary spherocytosis, G6PD deficiencies, thalassemias, and sickle cell anemias. These are the intrinsic factors pertaining to the RBC morphology or RBC enzymes. In hereditary spherocytosis, there is a defect in the structural proteins of ankyrin and spectrin. As a result of this, the RBC they become spheroidal in shape and they are less deformable. As a result of this, these RBCs they get entrapped in the sinusoids and get destroyed. Another is the G6PD deficiency. The persons with G6PD deficiency, they actually the G6PD is mainly essential for the formation of reduced glutathione, which is essential for neutralizing the H2O2. In G6PD deficient individuals, this G6PD is not there, so the reduced glutathione there is a deficiency. As a result of this, the H2O2 they gets accumulated and causes destruction to the RBCs. And other is the thalassemia and sickle cell anemia. And thalassemia is a quantitative defect in the hemoglobin, and sickle cell anemia is a genetic mutation where the glutamic acid is replaced by the valine. As a result of it, it causes the sickle cell hemoglobin. This sickle cell hemoglobin it undergoes polymerization when exposed to low oxygen tension or deoxygenation. These polymerized sickle cell, this causes polymerization of the sickle hemoglobin and causes the and distorts the shape of the RBCs, causing entrapment in the spleen and destruction. So, general features of a hemolytic disorder. On general examination, the patient will be having jaundice, pallor, and bossing of skull. There is any extramedullary hematopoiesis, we will have a bossing of skull. And physical findings, you will see an enlarged screen. And hemoglobin in initial stages of initial stages because of compensatory erythropoiesis, the hemoglobin levels will be normal, but gradually it decreases and present with severe anemia. And NCV is usually increased and reticulocytes are increased because of compensatory erythropoiesis. You will have a reticulocytosis and bilirubin is increased. And most of the time it is unconjugated bilirubin and there is a rise in LDH level and serum haptoglobulin might be reduced to absent. These are the general features of a hemolytic disorders. And coming to the workup of a hemolytic disorder, the common investigations which usually we do is complete blood. CBC suggests complete blood cell count, peripheral blood smear. C is biochemical parameters. It includes serum LDH, serum haptoglobulin, and indirect bilirubin. On examination of peripheral blood smear and reticulocyte count itself, we can come to a diagnosis of, to some extent, we can come to a diagnosis of hemolytic anemias, especially by looking at the RBC morphology. If there is any presence of cystocytes, fragmented RBCs, spherocytes, nucleated RBCs, it all indicates the presence of a hemolysis. And there's an increase in reticulocyte count. This is because of the compensatory erythropoiesis. And the serum LDH, serum haptoglobulin, and indirect bilirubin, these are the biochemical parameters which are increased in case of hemolysis. Among these three biochemical parameters, serum LDH and serum haptoglobulins are considered to be most sensitive tests because in few cases the indirect bilirubin may not always be increased. So with these basic investigations, first we can look for the hemolysis. To have a evidence of hemolysis, we can see in the peripheral smear. So here you can see, this is already explained previously. Here in intravascular hemolysis, you will see a hemoglobinuria and hemosideриnuria, and there is a mild increase in unconjugated bilirubin, but serum haptoglobulin is markedly decreased in intravascular hemolysis. Now coming to the other investigations, you can go for hemoglobinopathy evaluation in case of thalassemias and DNA analysis which though it is not routinely done, can be used to diagnose a hemoglobin variants like sickle cell variant, thalassemia minor and all. We'll do a DNA analysis and to determine the carrier state also. Carrier state also we'll do a DNA analysis and quantitative G6PD assay to detect the deficiency in this enzyme. And osmotic fragility test used in case of hereditary spherocytosis. And next is the test for autoantibodies. This is a Coombs test and all will do. If you are suspecting the autoimmune etiology, Coombs test helps us in diagnosing these cases. And the haptoglobulin and reticulocyte count. So it's the basic investigations, haptoglobulin and reticulocyte count. And flow cytometry for a suspected case of PNH, it's paroxysmal nocturnal hemoglobinuria. So these are the acquired or extracorpuscular hemolytic anemias. It includes IHA, that is autoimmune hemolytic anemias, which are again categorized into autoimmune and isoimmune. Autoimmune is of warm and cold type, and isoimmune usually occurs in post-blood transfusion cases. And other is the MAHA, that is microangiopathic hemolytic anemias, direct toxic effects, in case of sepsis, burns, severe malaria. Because of this, in these cases, you'll have a hemolysis. And next is the paroxysmal nocturnal hemoglobinuria, and other is the tropical splenomegaly. Especially malaria endemic areas will have a splenomegaly. Because of this splenomegaly, the RBCs they get sequestrated and destroyed, causing the lysis. And now we'll discuss in detail about the individual etiological factor. First is the warm autoantibody type of IHA. It's the most common, and the antibody is usually of IgG type. What happens is these antibodies they go to the RBCs, and these RBCs, these antibody coated RBCs, they get sequestrated in spleen and they get destroyed. So it's a extravascular hemolysis. These antibody coated RBCs are sequestrated in the spleen and are destroyed. So in peripheral smear, you'll see a macrocytes, spherocytes, NRBCs, and polychromatophils. So the causes for these autoimmune hemolytic anemias, 50% of cases are idiopathic etiology. There is no particular reason we'll have a idiopathic. And the secondary causes it includes connective tissue disorders like systemic lupus erythematosus, rheumatoid arthritis, and few cases because of the drugs, which can also induce this warm autoimmune hemolysis, and also lymphoneoplasms like CLL, lymphomas, and few disseminated malignancies also they induce this warm autoimmune hemolysis. And other is the cold IHA, that is cold autoimmune hemolytic anemias. Usually these are of IgM type, antibodies are of IgM type. These cold auto antibodies they causes agglutination of the RBCs and causes complement activation and results in the intravascular hemolysis. Usually, these agglutination it occurs in the peripheries of the body, that is in the fingertips and ears and ear lobules and toes. Here, the agglutination of RBCs will be more causing the lysis. So, the predisposing factors for this cold eye are in acute, it includes mycoplasma pneumonia, infectious mononucleosis, and SB, that is subacute bacterial endocarditis. Whereas chronic, it includes lymphomas, autoimmune diseases, chronic connective tissue disorders, and myeloma. Here you can see a agglutination of the RBCs. Next is the paroxysmal cold hemoglobinuria. Here the antibodies are of IgG type. They are directed against the E blood group antigen, and you'll see a hemoglobinemia and hemoglobinuria on exposure to the cold. Predisposing factors of few viral infections like Mycoplasma pneumonia, measles, few viral flu syndromes, and syphilis. It triggers this paroxysmal cold hemoglobinuria. So coming to the diagnostic workup in case of immune hemolytic anemias, you'll see a peripheral blood smear examination. You'll see a anemia, normocytic normochromic anemia with a few NRBCs, polychromatophils, and spherocytes. And reticulocytes, there's a marked increase in the reticulocyte count. And do a Coombs test you'll see a positive, we'll have a antibodies developed against these RBCs, and there's a increase in serum bilirubin levels, and there's a increase in LDH levels, and the decrease in serum plasma haptoglobulin levels. This is all about the immune hemolytic anemias. Next includes the microangiopathic hemolytic anemia. It's also called as fragmentation syndromes. It's mainly caused by the abnormality in the microvasculature. Because of the abnormality in the microvasculature, the RBCs are exposed to shear stress, causing trauma to the red cells, leading to fragmentation of the RBC membrane and forms the fragmented RBCs. And these fragmented RBCs can be of any type, can be cystocytes, burst cells, and helmet cells. So the predisposing factors for this MAHA is external trauma to the RBC. Basically, it's usually seen in soldiers and athletes because of marked strenuous exercise and the prolonged exercise for long duration. There's a shear stress to the blood flowing in the foot capillaries. As a result of this, there's a lysis in the capillaries, the blood flowing through the blood flowing through the capillaries in the foot. Another is the patients who have undergone this prosthetic replacement, aortic wall replacement, mitral wall replacement, who have undergone this who have this cardiac wall prosthetics. Then these, when blood flows through these processes or artificial grafts, they are exposed to shear stress because of this turbulent blood flow. As a result of this, it causes the destruction of the RBCs, forming the fragmented RBCs. And also in case of fibrin deposits in the microvasculature, especially in malignant hypertension and atherosclerosis, when the blood flows through these fibrin deposits, the RBCs, they get attached to the fibrin deposit, and it's exposed to the shear stress. As a result of this, the RBCs undergoes the fragmentation. And other cases where you see this microangiopathic hemolytic anemias are TPPs, that is thrombotic thrombocytopenic purpura, hemolytic uremic syndrome, DIC, that is disseminated intravascular coagulation, and vasculitis in collagen vascular diseases also will have this MAHA, microangiopathic hemolytic anemias. So these are the fragmented RBCs. At least more than 3 per 5,000 cells should be there to tell that the cystocytes are significant. The occasional cystocytes doesn't have a significance. At least more than 3 per 5,000 cells should be there to call the cystocytes as a significant in number. And at least 1 to 3 spikes should be there on the surface of the RBC. Next, coming to hemolytic anemia from the toxic effects, it includes infections like malaria, toxoplasmosis, septicemia, and in case of Wilson disease and lead poisoning also, you'll see this basophilic stiffening, which causes this hemolytic anemia. Snake bite, burns, thermal injuries also will have this hemolysis. This is a basophilic stiffening seen in case of a lead poisoning. Next is the hereditary spherocytosis. It's a autosomal inherited disorder. It is mainly because of a intrinsic defect in the RBC cell membrane. There are abnormalities in the ankyrin and spectrin protein, which are helpful for the structural integrity of the RBC. Because of the defect in these proteins, the RBCs, they become the spheroidal in shape and are less deformable. So when these spheroids, they flow through the spleen, these spherocytes, they get entrapped in the splenic sinusoids, and these macrophages, they anchor these RBCs, causing the lysis. And because of these dilated and the congestion of the splenic sinusoids, we have a splenomegaly. So outstanding morphological findings in case of hereditary spherocytosis are you have a spherocytes. Spherocytes are usually smaller than that of a normal RBCs, and you don't have a central pallor in this, and there's a increased MCHC levels. MCHC is always increased in case of a hereditary spherocytosis, and there's a reticulocytosis you have, and hemocytosis because of frequent blood transfusions and all. have this hemocytosis. And coming to the bone marrow, we have a marked erythroid hyperplasia. And these are special tests for this hereditary spherocytosis. It's a osmotic fragility test. These spheroid cells, they get lysed more readily in solutions of low salt concentration. So you have this increased osmotic fragility with hereditary spherocytosis. The patient have a clinical features of anemia, jaundice, and splenomegaly. Because there's a more lysis, he'll have this pigmented gallstones. And when the hereditary spherocytosis patient, when exposed to parvoviral infection, what happens is there is a suppression of erythropoiesis. So there is no compensatory erythropoiesis. The lysis is going on, but there is no compensatory erythropoiesis because of these parvoviral infection. It leads to catastrophic anemia. So aplastic crisis is a major problem encoded in case of in case of hereditary spherocytosis when exposed to parvoviral infection. These are the findings in case of hereditary spherocytosis. You'll have a reduced hemoglobin, MCD is reduced, and MCHC is increased. You have a increased reticulocyte count, and biochemical findings is have a increased bilirubin level, is a decreased haptoglobin level, and increased urinary urobilinogen. And in peripheral smear, we have a spirocytes, which are distinctive features of a hereditary spirocytosis. This and we have a normal WBC and platelet count. The special test for this hereditary spirocytosis osmotic fragility test, but it is less sensitive. Now we are using flow cytometry test for the eosin 5 maleimide protein. We'll tag this eosin 5 maleimide with a fluorescent stain and look for the intensity of this protein. And this intensity fluorescent labeled eosin 5 maleimide intensity is decreased in case of hereditary spherocytosis, which is not so in case of other hemolytic anemias. Next is the paroxysmal nocturnal hemoglobinuria. So it's a here the intravascular hemolysis occur and it's a episodic hemolysis. It occurs in episodes. We have a here in paroxysmal nocturnal hemoglobinuria. The patient complains of dark colored urine. The first sample, first void urine in the morning is a dark colored urine, and the other subsequent urine samples will be normal. The dark colored urine is mainly because of the presence of hemoglobin, which is there in the acidic urine, it converts into acid hematine and it gives the brown color. Why it is named as paroxysmal nocturnal hemoglobinuria is usually in the night times during the sleep, the pH drops down to 7.25 to 7.35. At this pH range, there will be a lysis of the blood. So the lysis of the RBCs and the hemoglobin is released in the blood causing hemoglobinemia. And this hemoglobin, when excreted in the urine, in the acidic urine, the hemoglobin is converted into acid hematine and it gives the brown color to the urine. The brown colored urine is the first void urine sample in pH is mostly dark or brown colored urine because of the acid hematine in the urine. And there's a and these PNH patients, they have striking predisposition to intravascular thrombosis in portal or cerebral veins and in the hepatic veins. When there's a portal vein thrombosis, causes Vijaya syndrome. And the specific tests for this PNH are Ham's test and sucrose hemolysis test. And we will also do a flow cytometry for a paroxysmal nocturnal hemoglobinuria. Next is the G6PD deficiency hemolytic anemias. In this G6PD deficiency, there is a defective glutathione metabolism. And this glutathione, reduced glutathione, is essential for oxidizing the H2O2 generated in the metabolism. There is a defect in this G6PD enzyme. The H2O2 is not metabolized and it gets accumulated in the RBC and causes damage to the RBC. It causes self-hemoglobinization, causing the destruction of the RBCs. And these RBCs are more vulnerable to the oxidative injury causing the hemolysis. So the factors which trigger this G6PD deficiency are drugs. When the G6PD deficient patients have taken these antimalarials or sulfonamides, it causes it releases oxidants which causes damage to the red cells leading to lysis. And infections like viral hepatitis, pneumonia, typhoid fever, and ingestion of fava beans also triggers hemolysis in G6PD deficient patients. And one interesting factor with these G6PD deficiencies, they have got natural protection from malaria because Plasmodium, it cannot survive in inside RBC because it needs G6PD enzyme for its survival. Since this G6PD deficient hemolytic anemia is intravascular hemolytic type, here you see a hemoglobinemia and hemoglobinuria. Usually, this hemolysis will be evident 2 to 3 days following exposure to oxidants. Then G6PD deficient individuals on exposing to oxidants, they develop this hemolysis and these hemolysis will present after 2 to 3 days. It is a special stain called as supravital stain to demonstrate these Heinz bodies, which are nothing but a precipitates of denatured hemoglobin. And on peripheral smear, you'll see a spherocytes and white cells. White cells are nothing but a cells which are where the inclusions are plucked by the splenic macrophages. The white cells are mainly formed because of the plucking of the inclusions by the splenic macrophages. So hence bodies and white cells are the characteristic features of G6PD deficient individuals. So peripheral bed, you'll see a decrease in HB, you'll see a anemia. There's a increase in reticulocyte count, and this in urine will have a hemoglobin urea, and this an RBC enzyme analysis will do quantitative G6PD enzyme analysis. It's a decrease. That is, the test becomes positive, and in peripheral smear you will have this anisocoagulophytosis, polychromatophilia, microspherocytes, and white cells and Heinz bodies. These are the white cells because the inclusions these are plucked up by the splenic macrophages and causes the fragmentation leading to this formation of white cells. So this is supravital stain. You can see a denatured globulin in the RBCs. Next is the sickle cell anemia. Sickle cell anemia is mainly because of mutation where there is a replacement of glutathione with a valine. As a result of this forms sickle cell hemoglobin, and these sickle cell hemoglobin, when exposed to low oxygenation, it causes sickling of the hemoglobin, and these sickled hemoglobin, it causes distortion of the RBC structure, forming the sickle cells, and these sickle cells they get entrapped in the splenic sinusoids and get destroyed in the spleen. So here on the peripheral smear, you'll see a reduced, you'll see a normocytic normochromic anemia. You'll have a increased reticulocyte count, and you'll see a sickle cells in the, which are the characteristic features in the sickle cell anemia. You'll see a sickle cells. We'll have a anisocoagulophytosis. We'll see a polychromatophores. And coming to the serum findings, here is the bilirubin is increased, and coming to iron status, you'll see a increased serum iron, transferrin, and ferritin. Iron parameters are increased because of frequent blood transfusions, and because of this lysis, there's a increase in the iron status. There's a decrease in haptoglobulin levels, and there's an increase in decrease in TIBC, the total iron binding capacity. In bone marrow, you see a increased cellularity. There's a erythroid hyperplasia, and the iron stores are increased in case of sickle cell anemia. So diagnosis in case of sickle cell anemia is by sickling test. We'll have a HB electrophoresis and estimation of hemoglobin, the fetal hemoglobin. And confirmatory test is mainly by HPS, that is high performance liquid chromatography. Sometimes you can also we also suggest prenatal genetic testing if there is a family history of this sickle cell anemia, there is history of consanguineous marriage. We suggest this prenatal genetic testing. Next, coming to thalassemia. Thalassemia is a quantitative defect in hemoglobin production. There's usually the hemoglobin is made up of 2 alpha chains and 2 beta chains. Here there is a decrease in the production of these chains. There's a defect in alpha chain we call it as alpha thalassemia. When there is a quantitative defect in production of beta chains, we call it as beta thalassemia. Okay. Because of this, the RBCs the hemoglobin, that's alpha or beta, it forms the tetramers in the RBCs, causing the deformation of the RBCs, causing the destruction. Okay. So in the peripheral smear, you'll see a marked microcytic hypochromic RBC anemia. You'll see anisopoikilocytosis, normoblast, and target cells. These are marked reticulocytosis, and indirect bilirubin is increased. TIBC, total iron binding capacity, is decreased, and the serum ferritin transferrin saturation are increased because of the frequent blood transfusions. For screening thalassemia, it should be done in the first trimester by chorionic villus sampling at 9 to 12 weeks and amniocentesis at 14 to 16 weeks, and genetic counseling for parents if you are for antenatal. If there is a suspicion of thalassemia running in the family, the parent should be given genetic counseling. Okay, the diagnostic test for the thalassemia is electrophoresis. Electrophoresis is mainly considered, and the next is the HPLC, it is high performance liquid chromatography. So previously in the bone marrow, you see hypercellularity, you see there. This is increased erythropoiesis. The bone marrow is increased. In spite of increased erythropoiesis itself, the bone marrow iron is increased because of repeated blood transfusions. Right? You see a bilirubin is increased and urine urobilinogen and is increased, and serum haptoglobin is reduced, and serum iron status, that's iron, ferritin, transferrin, and all are increased, and TIBC is reduced. And the special test for this is HB electrophoresis, HPLC, that is high performance liquid chromatography, and estimation of globin chains, and Nestrov test. Nestrov test is a little bit, it has got less sensitivity when compared to that of HPLC and HB electrophoresis. Nestrov test is nothing but naked eye single tube osmotic fragility test, which is positive for beta thalassemia. Okay. So with this, I am concluding this section. Any doubts?
A nice presentation, Vasundhara. Coming to the peripheral smear, spherocytes are seen in various other hemolytic conditions. So, what is the definitive diagnosis for hereditary spherocytosis? Is it peripheral smear or?
So your voice is not audible, sir.
For hereditary spherocytes are seen in various hematological disorders. Like in G6PD also there are
Yes, sir.
spherocytes. Hereditary spherocytes also there.
Yes, sir.
What is the definitive
Yes, sir.
diagnosis for the hereditary spherocytosis?
Sir, for definitive diagnosis for hereditary spherocytosis, we'll do a flow cytometry, sir. Flow cytometry with eosin 5 maleimide. We'll do a fluorescent labeling of the eosin 5 maleimide RBCs. We'll see the intensity of these cells will be decreased in case of hereditary spherocytosis, which is not so in case of other hemolytic anemias.
Thank you, Vasundhara. Nice presentation.
Oh,
Any
okay.
I think there are no questions. Let us close this session. Thank you, Vasundhara, for presenting the wonderful presentation. Thank you.
Okay, thank you.